Unlock the future of radiology with Radiology News. Your source for the latest insights, expert views, and innovations shaping the world of radiology. Don't just stay informed, stay ahead.
Hello and welcome to Radiology News. My name is Sidney Ocanagil-Tunstall. I'm the Marketing Director for Radiology News. And today we're talking about enhancing MRI imaging through the use of USPIO, and that's ultra-small super-paramagnetic iron oxide nanoparticles. Now, this conversation comes off the back of a long-awaited phase 3 clinical trial, and the results suggest that clinicians may be able to detect metastatic lymph nodes with far greater sensitivity than conventional imaging methods allow today. Previously, this hasn't been possible, and we've seen a detection gap that has left those small cancerous lymph nodes undetected. To talk us through this, I'm delighted to be joined by Professor Jelle Barentsz, a true visionary and expert in medical imaging and lymph node detection. Jelle, welcome to Radiology News.
Thank you.
Good to have you here. Jelle, to start with then, I was hoping we could learn a little bit about you and how you got into radiology and what your interests are.
Well, I'm a radiologist, and a radiologist is fighting cancer using images. So I make preferably nice images. I'm also a nature photographer, so I like nice images to help my fellow clinicians to give the best treatment for the patients. And well, an image tells more than 1,000 words, so imaging is really important.
Yeah. So moving the conversation on to detecting lymph node metastasis then, specifically in prostate cancer, and historically it's been such a difficult puzzle to solve. Can you talk us through that?
Well, the problem with metastasis is that they're very small, and small structures are very difficult to recognize. You talk about metastasis of 2 millimeters, and if you have a 2 millimeter metastasis, which is like this, it already makes the difference for the patient, because it doesn't matter how big your metastasis is. If it is a metastasis, the tumor is growing into the body.
Yeah.
So we are looking at very tiny structures, which usually are also hidden behind all kind of other organs, vessels, nerves.
Yes.
So it is problematic to find them. In the very past, I talk about in 1983, we were visualizing lymph nodes by making a cut in the foot, put a needle into a lymph vessel, and then have oily fluids drip into the lymph vessel. That took about 3 hours to be filled, and the next day you could make an image, a very obscure image of a certain part of lymph nodes, and you didn't see everything, so it was difficult. Terrible for the patient and difficult. Then we had CT, but CT was not able to recognize the lymph nodes as conventional MRI because they were too small. Thereafter we had PSMA PET-CT, which shows actually the biology of lymph nodes and of its metastasis. But also PSMA is limited. So the problem is you want to detect the tiny bad guys early on.
I think it's fair to say that imaging has come on so much since 1983. It's really incredible what we can do now. I really want to focus down onto these nanoparticles then. Can you tell us about how you came across them and how they're playing an active role in this?
Yeah, in 1990 I saw a publication where in a rabbit, normal lymph nodes turn black after the infusion of this iron particle. Intravenous infusion, not the lymph vessels, intravenous. And abnormal lymph nodes remain white. They said, hey, this is fantastic. There's something happening. I can recognize pathologic lymph nodes. And the way it works is the lymph nodes consist of very tiny iron particles, 50 nanometers, which is about 1/10,000th of the size of a hair. Very small. You can inject them. They go to the macrophages. Those are the Pac-Mans, the all eaters of the body. So they eat the iron and they turn black. Now, normal macrophages are present in lymph nodes. In normal lymph nodes. So a normal lymph node, instead of being white, it turns black. Whereas if there are metastases,
Yeah.
it remains white.
Sure.
Now, if you suppress the background, we can do that, and making it black. You only have to look at the white dots, and irrespective of size, you can see them. Also, irrespective of the tumor.
Mhm.
It doesn't matter whether you have prostate cancer, bladder cancer, pancreatic cancer, lung cancer. A white lymph node is bad. You see it. So this was a fantastic agent. So that is why I was so enthusiastic about it already in 1990.
Fantastic, and thank you. Now, obviously, I was at your talk yesterday, and
Mhm.
you coined this new approach, but it never entered mainstream clinical practice, and it's only now that it's going through stage 3 clinical trials. So, can you talk us through what the holdup was there?
Yeah, registration of a contrast agent is difficult because if you have the registration process, a contrast agent is considered to be a pharmaceutical product because it does something in the body. So it follows the rules of pharmaceuticals. But if I give you a full syringe of iron, it doesn't cure. It only makes images better that help you cure. Nonetheless, the EMA and the FDA, they more or less follow the rules of therapeuticals. So it is like playing hockey with soccer rules. And that is not good. So that was one obstacle.
Yes.
But you can overcome that obstacle, no problem. The other thing is that the companies, they were not really aware how they should design the studies.
Right.
So they had suboptimally designed studies which didn't show the difference to be significant.
Yeah.
And last but not least, we already talked about it, the gold standard is the silver handicap. So the gold standard was required, that is surgical removal and histopathology. But if 80% of the lymph nodes that are positive remain in the body, what is your gold standard?
Yeah.
So that was a problem for the pharmaceutical companies to get it approved.
Yeah.
And they, due to the economical crisis, they threw it away in 2008.
Yeah. Yeah.
Then I said, no, this is a new revolution in radiology, something good for mankind.
Yeah.
So I was persistent and
Fantastic.
I managed to get hold of the documents, the rights, the
Yeah.
production process,
Yes.
and my university bought it for a minimal amount of money.
Yep.
And they were able to remake it in the
Yeah.
Netherlands,
Grand.
give it to patient based on a patient name basis, and show that it was identical.
Yeah.
And then they founded a small startup company. Well, not founded, they found a startup company called SPL, as Save Patients Life Medical. And they, together with me and my colleague, Dr. Zamechnik, we made an optimal study design because I learned from the mistakes. I was there when the mistakes were made before. So we had an optimal design, and that finally resulted in the things I presented yesterday.
Yes. Yes.
The primary objectives were met.
Yeah.
We proved that the new contrast agent was superior in sensitivity in the detection of small lymph nodes compared to the unenhanced MRI.
Yes.
And that the specificity, that means if you say yes, it is yes, was equally high, about 95%.
Yes.
So the primary objectives of the study were met, and that was it. So now there is a long administrative process of the marketing authorization that takes place. That takes about 1.5 years. So
Okay.
we are now halfway. So we expect this agent to be approved by the end of this year or quarter of 2007,
Okay.
2027.
And sticking with the clinical trial now, obviously you mentioned the specificity and sensitivity there. How does that compare to the techniques that we use in routine practice today? I'm aware that we use PSMA, PET at the moment.
But PSMA PET, you cannot recognize lymph nodes that are smaller than 4 to 5 millimeters because of the resolution, limitations of the technique itself.
Mm.
Whereas with this new technique, you can recognize lymph node metastasis as of a size of 2 millimeters. So it fills a gap between 2 and 5.
Yeah.
And a lot of lymph node metastases have that size. So what you actually do is you recognize them early on
Yeah.
So you can also treat them early on, kill them early on. And the
Exactly.
earlier you kill the enemy, the smaller the enemy is, the better it is, and the less radiotherapy, for example, radiation you need to use.
I love it, and I love the analogy there. So with all that in mind then, and the high sensitivity that you're seeing here, do you think this could act as a new gold standard?
Well, that's difficult to say because it needs a rethinking of what is the golden standard. And we traditionally think that, well, we consider removal in histopathology to be the golden standard.
Yes.
But if the golden standard isn't even a silver handicap, it's difficult to cope with. For example, urologists, they didn't quite understand that we were seeing lymph nodes still there after their meticulous surgery. The acceptance of the surgeon that he left something behind and that the golden standard is actually not good is rather difficult. And also probably the authorities have to rethink. But yes, in the end, I think you're right. The golden standard will be replaced by imaging. What you see, for example, in Australia is that PSMA is rather good. Can be better, as I told. But PSMA in Australia is now the golden standard for the detection of the presence of metastasis, and less patients have now pelvic lymph node dissection anymore. So lymph node dissections go down because urologists know the limitations. In our studies and also other studies, we found that about 2/3 of the lymph nodes, the positive lymph nodes on imaging, were left behind.
Yeah, wow.
That's an enormous amount. It has been shown in literature that it has no therapeutic effect, and also now the staging effect, that means the detection effect, is also limited.
Yes.
I think that will be, finally, this will be a game changer.
Yeah.
But the problem is, and was, to get this approved with the old, limited golden standard.
Yeah.
And I'm very happy that that succeeded.
Yeah. And we've figured out approval there, but what about implementation? Are there any challenges towards how we actually implement this in practice?
Yeah, with any new technique, there are a lot of implementation hurdles. One of the biggest hurdle is the radiologist should know how to use this. He should learn this. When I introduced PIRATS in 2012, the radiologist had to learn to use the PIRATS system, which was rather complicated.
Yes.
Looking at lymph nodes and the way you are diagnosing them, personally, I think learning to recognize pathologic lymph nodes is easier than learning PIRATS.
Okay.
And we managed to learn PIRATS due to educational courses.
Yes.
So education is important. You localize the lymph nodes, then you go to another sequence and you say it's black or white. Okay, it's black, it's good, it's white, it's bad. That's easy. So it's easy to learn. Also, AI may play a role. So I think I'm optimistic. But if the product is sold, it automatically goes with an educational program.
And you mentioned AI there. Is obviously that would be a image analysis tool that would look for the contrast between black and white and the different lymph nodes and their sizes. Is that something you'd like to play a part in the future, developing that algorithm?
I think it's very important that we are using that algorithm because what the problem is not recognizing the lymph nodes, but you have the pelvis, an enormous structure with multiple organs, dots, vessels, things that look similar to pathologic lymph nodes, and you need to pick up the white guys which are there, which are bad. And that is quite a time-consuming thing. And I think that if you put in an AI algorithm that automatically recognizes vessels and normal structures and you can subtract them, then you only see the bright dots there, which are abnormal. So yes, we did some work in the 2008, around that time, with the early AI, deep learning, and it showed already good results.
Yes.
Yes, so I'm very optimistic about that. But first, it needs to be on the market.
Yeah,
Second,
absolutely.
and that is of course another implementation hurdle. Radiologists and clinicians, they should recognize what the clinical value is. That if you recognize small lymph nodes, what can you do with it? Is it nice to know that you have a small lymph node? without any significance? The answer is no. If you do radiotherapy to the small lymph nodes, just a tiny mini amount of radiotherapy, you kill them, and the patient is cured.
Yeah.
So they have to learn to use it.
Yeah.
We are the
value of
same.
it.
We are the same with bowel examination. We don't do it anymore. But in the past, we had single contrast bowel where we didn't see polyps, and then once of a sudden, with double contrast, we saw small polyps of 5 millimeters. And the gastroenterologists, they would think, what's the relevance? What should we do with the polyps? Now we know that you should remove polyps because they can turn malignant. But at that time, we had to think about it. Do we see what we see in you is relevant?
Yes.
The answer is yes with those lymph nodes. Of course, because it is metastasis.
Yeah.
What we say in the Netherlands, the bird is out of the nest. And just so yes, you need to find that bird.
Yeah. Fantastic. And, to stay on the subject of implementation and how this could be adopted practically, we can't have that conversation without discussing the economics. Is it economically viable? How does it compare to PSMA, PT?
Yeah, of course, that's a very important question with the aging of the population and the increasing demand on healthcare. And well, yes, the answer is we did a cost-effective evaluation with a so-called Markov modeling. That means that you start with the diagnosis, which can be done by surgery, PSMA, or macrophage MRI, and then you see the effects, immediate costs, and the effects in a lifetime course.
Yes.
So what will happen with a patient who had surgery in his lifetime? Will he develop metastasis? Will he suffer from all kinds of things or not? And what are the costs? So we calculated that. And we found that the lifetime costs of surgery versus macrophage MRI was 10,000 euros more. And then the cost of PSMA versus macrophage MRI.
Yes.
Macrophage MRI was about 2,000 euros more. And we actually made an app, an Excel app, where you can fill in the sensitivity, the specificity of surgery, PSMA, macrophage MRI, and also the cost. So you can vary that and you can see what the outcome is with respect to cost effectiveness. So it's easy for any clinician or anyone, a healthcare provider or a director of a radiology department to see, okay, if I have that, what is...
This makes sense.
Yeah.
And on so many levels as well. From the medical point of view and the economical point of view.
And patient point of view, yes.
Yeah.
Yes.
And let me ask you then, do you see a timeline for when we'll see this in your routine practice?
The timeline will be that the agent will be available by Q1 2027.
Okay.
Then people will go to buy it. I think initially they're a little bit hesitant, but then there will be, after about half a year, a rather explosion. People are using it, trying to figure out how can we do it, what are the sequences with MRI. Of course, with education we help, and then they find their way. It will grow and grow and grow and grow, and then after initial optimism it will go down a bit, and then it will go up again. I think that within 5 years we will see about 60% of the impact of this agent. And the impact is not only lymph nodes, it is of multiple sclerosis. You see the active multiple sclerosis that has already been proven by papers, by research. The active multiple sclerotic plaque.
Yes.
So the recurrence of activity. You see it before the blood-brain barrier is damaged. That is very early. And you see also only the very aggressive plaque. So with this agent, because the macrophage is present. So you can treat a patient with very expensive drugs. In arteriosclerosis, we all have plaques in our vessels. You probably a little bit less than I because I'm a little bit older. It doesn't matter. But if a plaque in my carotid artery is going to rupture, to loosen, I will get an infarct. Now, the process of loosening goes together with inflammation in the vascular wall. And now, tell me what is there in the vascular wall at that moment? Macrophages.
Okay.
And they are black. So if there's blackening in the wall, the plaque is going to loosen. So before the plaque loosens, you need to do something. Give anticoagulant drugs or, well, local treatment or whatever. So you are ahead of the infarction. As I said, it works in all the cancers. In brain tumors, you can have a better differentiation between very aggressive tumors and less aggressive tumors. In rheumatoid arthritis, you can see the macrophages present in active rheumatoid arthritis. In kidney disease, you can see it. And the other winner is, it is a so-called blood pool contrast agent. It stays in the blood for about 5 days.
Yes.
Then it's being taken up by the body into the bone marrow. So also the bone marrow turns black, so bone marrow metastases are recognized better. But it is in the blood, so it is a blood pool contrast agent. So the vessels are bright.
Yes.
So you see the vessels. It's iron, you can give it to any patient. So if you have poor renal function, I cannot do a CT with contrast because it kills your kidney.
Yep.
I cannot give gadolinium because you get the side effects of gadolinium in your body. But iron is no problem. So with this stuff, if you have a renal insufficiency, I can visualize your vessels very well. Tiny vascular structures.
Yeah.
And there's also a new world of research. You can see the vascular shape and form and quantify it. And it plays a role in various tumors and the aggression of tumors. So there's still a new area to be explored.
Yeah, absolutely. And I mean, it's really, obviously my focus is really oncology, but it's incredible to see how many applications there are for something like this. And, there's probably a few there that we haven't talked about as well.
Well, talking about neurodegenerative disease, inflammation, I question perhaps Alzheimer's, Parkinson.
Yeah.
I don't know.
It's a disease we know so little about.
Yes.
But there's certainly scope there.
The problem is, it was in 2008, it was growing the experience and everybody was enthusiastic. And then the companies had to stop.
Yeah.
Both. It wasn't there anymore. So now, in 2027, we have to start where we left in 2008.
Yes. Okay. Interesting.
Using your publications.
Yes, and we are glad to be helping in that.
So that's why I'm so enthusiastic, and that is why I fought for 36 years to get this contrast agent back. And it's just,
that's what I wanted to ask you about. This has been a huge project in your life.
Yeah.
You've had to persevere through being declined initially, and come back to it with more motivation. Where you found that, I don't know. But how does it feel personally to have this, through clinical trials now, and perhaps, seeing it in routine diagnostic care in January 2027?
Well, it feels like a victory, and not a victory for me. Of course, yes, it is a victory for me, but more for the patient.
Yes.
I saw what it could do to the patient, and I was really frustrated that I couldn't help more patients. Patients came over to me in Nijmegen. They went back to the US, and their examination was already earlier in the US. The radiation oncologist treated them according to what I saw in the images, and they were cured. Patients still are living, and I met patients on meeting. They said, "Professor Barentsz, yes, you saved my life." And okay, this gives me motivation, and I was so frustrated that it stopped in 2008 and that it took so long before approved. And now finally it is approved. And well, for me, it is such a good feeling that we are now able to treat patients a lot better than we could because of superb imaging.
Yes.
So yes, it is a fantastic feeling.
Yeah. Well, just to begin to wrap this up, I just wanted to thank you for joining us today. It's been a real pleasure having you on.
Okay, thank you.
Really fascinating story. And also it's amazing to have another individual join us on Radiology News who's contributing so much to this field. So thank you very much.
Well, it's a pleasure. And I'm happy to be here and happy to, to share my good news to your listeners.
Yes.
And whenever they have questions, they know where to reach me. I have a website, you can find me.
Grand.
Also my nature photography, because I like pretty images.
So to ask you one final question then, if you had any advice for anyone practicing radiology, and whether that's research or in clinical care, what might you say to them?
The advice I have for you, and actually not only for fellows in radiology or colleagues in radiology, but I think to everybody, you should once in a week or once in 2 weeks, stand in front of the mirror, look at yourself, and ask yourself, why am I doing the things I do? Is that for me, ego? Is that for euro, money? Or the last E, is that for empathy, for the patients? And it is a mix. But for some of us, ego is the most important thing. And for some of us, money is the most important thing. And for others, the patient is the most important thing. But it doesn't really matter what your shift is between the 3 E's, as long as you know it, you are aware of it. So you should be concerning that aware competent instead of unaware incompetent. So learn about your own 3 E's.
Yeah. Fascinating. A lovely way to end it, I think. Thank you so much.
Okay, you're welcome.